So good evening, everyone, and thank you for coming to the Dr. Roger Bland lecture series on improving children's mental health. As you know, this is presented by CASA, Child, Adolescent, and Family Mental Health, along with our many partners, the Institute of Health Economics, the Edmonton Public School Board, the University of Alberta Department of Psychiatry, and the Alberta Alliance on Mental Illness and Mental Health. I am Dr. Denise Milne, and I'm CEO of CASA and the CASA Foundation. Tonight is our very first lecture in our series of the 2019-2020 season, and we're really excited to go into our second year. Tonight will be a conversation about trauma. So what does that mean? How does it affect our children and youth? And how can we best help those, including ourselves, who are affected by trauma? As you know from the previous lecture series, it is our goal with the Dr. Roger Bland lecture series to provide information that is meaningful and helpful. We want to inspire dialogue, hope, and wisdom throughout the series. We have a number of key speakers that we've lined up for the series. Tonight we have a fantastic keynote speaker and some really well-rounded, solid panel members. So this conversation is about learning and growing. So now I'd like to introduce our moderator, Leslie McDonald, who you will recognize from previous season of our lectures. Leslie is well known in the community for her work with Global, other community initiatives, and her communications company. It has been a great pleasure to work with Leslie on our lecture series, and we look forward to this upcoming year. Thank you.
Thank you, Denise. It's been wonderful. What a great season we had last year, and we're looking forward to another one this year, and part of what makes it great is hearing from you and having that feedback and that dialogue and getting your energy back up with us as well. I'm going to begin by acknowledging that we're on Treaty 6 territory, a traditional meeting ground, a gathering place, and traveling route to the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. Just two housekeeping notes before we begin. Keep your cell phone on in case you want to tweet or do anything on social media, but please turn down the volume. And if any of you need to find the washroom, and if I'm out of breath, it's because I just ran from there. It's quite a ways away. You go down the steps here, and it's sort of halfway around the rotunda, and then you'll see it on your right-hand side. Now, for those of you who are joining us for the first time, our format is we begin with our keynote speaker, and that's followed by our panel discussion. And then at some point, we're going to include you in the conversation, and we look forward to hearing your questions. As Denise mentioned, our topic this evening is surviving trauma, and it's probably one of the most important topics of the series for this season because of its scope and the scale of its impact on public health. Early adversity dramatically affects both mental and physical health over the course of a lifetime. And again, as Denise mentioned, what does that mean? We are so fortunate to open the discussion with noted Canadian child psychiatrist, Dr. Andrew Bremness, who I'm sure you will come to love. Dr. Bremness is a clinical professor in the Department of Psychiatry at the University of Alberta. He is also a consulting psychiatrist in the Child Health Unit at the Misericordia Hospital. But he's probably best known for his work with CASA's trauma program and the Trauma and Attachment Group, otherwise known as TAG. So here to tell us more about his work and the impact and what he's learned, please welcome Dr. Andrew Bremness.
So I'm going to try and wander around. So apparently the beanbag chairs aren't so popular, but if anybody really wants to relax, there's beanbag chairs back here. And then I got to turn this guy back on, I think. Oh, no, here we go. So our talk tonight is on trauma, and trauma means that something bad has happened to you or one you love, and trauma is ubiquitous. It happens to everyone. Some of us don't survive trauma nearly as well as others, and we're going to find out why tonight. So I'm supposed to say to you that this is a little bit who I am, that Leslie just introduced, and that there's no disclosures, because I'm not here to sell you a medicine, or I'm not here to sell you a particular therapy. we're going to talk today about 3 areas. And you'll notice that in these 3 areas, it doesn't mention treatment. But treatment's going to be dotted throughout these 3 areas. How the brain grows and how it normally develops, so what we should expect from normal, healthy growth and development, and how trauma interferes with that. Specifically, then number 2, how trauma interferes in children who have experienced especially repetitive trauma. Number 3, our ACE research. ACE stands for Adverse Childhood Events, and how that looks in the adult population, because we need to know what to protect our kids from as they grow old. And it turns out it's pervasive of how much trauma interferes with typical adult life. So let's start with our brain. So if this was your spine and my hand is your brain, and say my thumb is the eye, so this person's looking this way, the brain grows from the bottom to the top and the back to the front. And it begins in utero, and it grows up the brain, and the back of your brain, the big visual cortex, is about a third of your brain at the back, and the very front here is what we call the executive functioning and the prefrontal cortex, and that's actually what matures last. And in healthy people, it matures around 25, and in kids who are vulnerable, autism, ADHD, learning disabilities, and trauma, it may take till 30 before the executive functioning is done. So, in very simple terms, there's 3 areas of your brain you want to know about. So the bottom of the brain is what we call, down here by the skull, the base of the skull, is our lower brain, or our brain stem and midbrain. So when we're born, that's what we're born into, and we like to call this your sensory motor brain. So all your knowledge coming in is through sensory input, and all your energy going out is through motor responses, because your thinking really hasn't turned on yet, and even your emotions really haven't turned on. And just so you know, when the baby smiles at you, this is going to hurt some moms, I think, that's a reflex. I'm sure they're happy, but that's a reflex. So in fact, you'll take care of them and you'll hold them, and things we'll talk about a little bit with attachment. So the middle of the brain is our emotional brain, called the limbic system. It's quite complex, has a bunch of different neurons and way stations in it, and we'll talk about 1 or 2 of those. And that starts to turn on around 2, and it sputters on, so we call that the terrible 2s, because there's no emotional regulation, but there is some emotion. And then around 4 sometime in our preschool years, our cognitive upper brain starts to turn on, and it's on enough by about 5 or 6 so we can actually send kids off to school and expect them to learn something. So 3 areas of the brain, and that's fairly simplistic. Any neuroscientist will tell you, well, come on, it's way more complex than that. But it's a good way to start, because one of the things I'm going to ask you to think about is when you're responding to any child, but especially a child who's known trauma, you want to ask yourself, and this is parent, teacher, therapist, youth worker, etc., anybody who deals with kids, where in their brain is this child? Are they in their lower brain? Are they in their midbrain? Or are they in their upper brain? If they're in their upper brain and quite rational, I can talk to them in language. So we can talk. But if they're in their midbrain and fairly dysregulated, the idea is to get to the middle of the brain and calm this kid down. So if talking isn't going to work, because that's not where they are, and that's why you sometimes get this feeling like I'm talking to a brick wall, like nobody's home. In fact, for that moment, nobody is home, because let me show you a little, well, before I get to the next chart, some of you may be surprised that the brain is actually 80% a social organ. We think of this lump of clay up here as something that's running the body. Only about 20% of your brain runs the body. The other 80% deals with the environment, and trauma makes the environment unsafe. So the brain gets hijacked by trauma because 80% of the brain is worrying about how I'm going to deal with the environment and social relationships and being able to read the environment around us, and are we safe and are we unsafe, and we don't know how to make good choices if we can't read the environment. So, this is a picture of a child and what their brain would look like. So they're mostly down their brain in their brain stem. That's survival mode, or what we sometimes call our lizard brain, things we share in common with the littlest creatures on Earth. And then the midbrain does some more, but kind of basic stuff, still sensory motor. And this is what OTs, one of our wonderful speakers here today, will tell you more about, because when we talk about bottom up, we're talking about coming in at the midbrain and using sensory motor strategies to get to the middle, which is the limbic system. And that's where the kids will then emotionally regulate and calm down. And the littlest tiny bit up there is their thinking brain, where you can actually talk to them. If they're up there, you can have a good conversation with Johnny, but if you wonder why does it seem like I'm talking to a brick wall? Because Johnny's not home up there. Johnny's down his brain. So the brain growth is sequential and it's governed by a series of genetic inputs, but it's also governed by the experience, because we know that any genetic input will only manifest itself in a certain environment. So if anybody asks you, well, gee, is this nature or nurture? It is by definition both, because whatever set of genes you're given, those genes will act differently in different environments. So for example, at CASA, we always promote a bio-psychosocial spiritual treatment plan. So the biology is, all right, what's happening in the tissues, and for the brain, that's the neurotransmitters and the hardware, if you will. The psychological is what's happening inside your skin, memories, thoughts, and feelings. Socially, it's peer relationships. Well, it begins with attachment, parental relationships, social relationships, teacher relationships, and out from there. And then spiritual simply means the meaning of life. And one of the things that trauma robs from us is the meaning of life. So, the other principle I'd like you to see on this slide is that regression is much more common and happens on a dime with children. So they can be in their upper brain one moment and some stress hits them. Like, for example, a common stress for kids is, I was caught. Even at little things. I forgot my math at school. But the idea of being caught stresses kids, and they'll start to regress. And so if you want to have a talk with them about, well, why did you leave your math at school? The response you'll probably get is, I don't know. And it'll come with a bit of an edge. Because, first of all, they're not in their thinking brain, so they literally don't know, because that's not where they are. And then second of all, they're afraid of being caught, so they've already got their defenses up about, no, you can't catch me, because if you catch me, you'll take my video game away from me or something, right? So regression is dramatic in most kids, normal kids, but with kids who have known trauma, regression can send them way down to the base of their brain. And so fight or flight, which, as you know, that's a common phrase when we describe what happens with trauma, fight or flight will take you all the way down to your brainstem. So fight on one hand can get all the way to rage, like a hissing, spitting animal, and flight can be flight, which means I'll leave, or I'll barricade myself in my room. Freeze, which means the child's frozen and can't move or can't think. It's a little bit like being in shock. And then even to fall. So we have kids who literally pass out when they get too far into their flight mechanism. By the way, if any of you are trying to remember any of this, we hope to get these slides up on the CASA website. So there's no test at the end of this. So here is the typical developmental stages of children. And developmental stages of children need to be understood because when I were to ask a parent, okay, what age is your child functioning at right now? And by that I mean, what is the developmental age of this child? Okay, we all know what the birth certificate age is. This child's 10 or 12 or 6 or whatever. But the developmental age will be how far they've regressed down their brain in that moment of functioning. It may be different a half an hour from now. It was certainly different a half an hour ago. But in this moment, you need to ask yourself, where is this child in their brain? Because that's going to tell me how to respond to this child. Again, parent, teacher, therapist, whatever, whatever your relationship with kids is. So so in utero, child experiences the stress that the mother experiences. In fact, this may surprise you, but from about 0 to 3, birth in utero, so before birth, and from birth to about 3, whatever happens to the mother happens to the baby. So I've heard people tell me, well, the mom got abused, but it was okay because the baby was in the crib, or the baby was in the next room, or she shielded the baby, or whatever. But about 0 to 3, maybe longer, certainly in utero, whatever happens to the mom, it may as well have happened to the kid. Right? So that's just a principle when we deal with infant preschool, which in fact will be one of the talks in this lecture series. So 0 to 1 is infancy, 1 to 3 is toddlers, again, mostly in their sensory motor brain, but emotions in the middle brain, the limbic system began to turn on. This is the terrible twos. 3 to 6 is the preschool years where they begin to think, but it's again sort of sputtering on. These include the magic years, so that's when Disney princesses become important, or whatever boys are into nowadays, Avengers or whatever. 6 to 12 is the elementary school years, and this is where we really begin to develop our neural circuitry. And when I said the 3 areas of the brain, lower, mid, and upper, were fairly simplistic, the actual thing you want to know is this neural circuitry, and that begins in earnest in the elementary school years. And this may surprise you, but in elementary school, we think kids are learning the 3 R's. Reading, writing, and arithmetic, right? Because, if there's teachers in the crowd, that's what you think you're doing, right? But it turns out in the elementary school years is about finding safety in the physical universe. If you understand Piaget and what cognitive development is, kids are learning in social and math and all the rest of it how to stay safe in the universe. Not just physically safe, but emotionally safe, relationship safe. So really, growing up is about developing a safe place. And that's a little bit about what trauma robs from kids with trauma, is a sense of safe place. So if trauma interferes with learning, they still may get a good grade on the math test or the LA test, but they're not learning enough about safety because they don't trust safe place, because it got wrecked at one point. And then 12 to about 25 is what we call the adolescent years. And never mind this silly business of 18 is the legal age. And some of you know why 18 is the legal age. It's because when war was on, that's when we needed men to come and fight the war. So we need to declare them adults. But it has nothing to do with biology. In biology and development, adolescence goes at least to 25, and then most of the kids that we see at CASA, 30. And sometimes that's when it finally feels like the kid has grown up, right? Finally gets it. So there's 3 things about adolescence I'd like you to know, because they happen to anybody anyway, but they have a special twinge to them when trauma is involved. So the brain is sped up in adolescent years. And the first reason is because pruning. Somewhere between grade 4 and grade 6, the brain starts to prune itself. So imagine your desktop computer at home, and it's way too crowded with apps or whatever that you don't ever use anymore. So if you got rid of your apps, like cleaned up your desktop, your computer speeds up. That's why we do that stuff, right? So what the brain does is it prunes itself between about grade 4, grade 6 to grade 7 maybe, and it starts to speed up because it's got rid of a lot of apps that it doesn't use. It doesn't mean you can't bring that app back on board. So for example, there is a music app in everybody's brain. But if the kid hasn't taken music lessons or hasn't used that music app, it's going to go to the back of the brain or in the trash someplace. But just like on your computer, you can bring things back out of the trash and start them up, and someone learns a guitar at 15, and boy, off they go sometimes. So the brain is pruned. But what happens when you prune a bush in your backyard? You trim it back, and there's going to be some dieback, right? And then you think, all right, never mind, next spring it's going to come out like full blossom, right? So in grade 7, 8, sometimes you'll say, well, what is wrong with my kid? It's like his brain has gone off, and he's just like in a la-la land. Well, there's a bit of dieback when the brain gets pruned, just like it would be for a bush, right? So the next thing that happens in adolescence is myelination. Myelination is where the nerve, every cell is connected with 1,000 other cells. So 1,000 times 1,000 times 1,000, and eventually get to 1 trillion connections in the brain. Well, all of those connections around early adolescence, there's a fatty sheath that starts to coat those nerves. And what it does is speeds up the transmission by about 3 times. And that's why teens are difficult, because they're thinking way faster now, and they can catch us, adults, in things like hypocrisy. Whereas elementary kids are kind of cute, they line up, they cue properly, they generally listen to us. Teenagers want to question everything because their brains are way faster. Not because they suddenly turned bad, it's because their brains are way faster. And part of that is because it's myelination. One cute little example of your brain being hijacked is in your midbrain on both sides. Just think about right in here someplace inside your cheeks. There's something called the nucleus accumbens. And this is about an almond-shaped little core of nerves. And it's called your pleasure center. And in adolescence, your pleasure center, or this nucleus accumbens, hijacks your brain so that everything you want to do, think, say, or feel gets hijacked towards pleasure. And it's not just, sort of drug, sex, and rock and roll pleasure. It's everything is pleasure. So it's the best music ever written. And that's why all of us loved the music when we were teenagers. That's the show we want to go to. For me, it's the 60s. That's the best music ever written. That's what my nucleus accumbens says. And for you, it'll be whenever your nucleus accumbens. But what happens is this particular little nucleus of cells grows like crazy during adolescence and starts to die back and go away in the 20s. And that's another reason by 30, people have seemed to finally mature, because instead of it being hijacked to pleasure, and I'm talking about pleasure like in learning or in causes. I want to be an animal rights advocate, or I want to be vegetarian, or I want to be, whatever, causes. The greatest pleasure in causes is late teens, early 20s. I mean, I grew up in the 60s. We used to think, well, the hippies turned on us when they were 30 or 35 because they finally got jobs and they actually got elected to government and whatever. But it's because their nucleus accumbens started to fade away, and by 30, everything's channeled back to the executive functioning portion where it's supposed to be, and they did turn out to be reasonable people. Okay, so these are the 4 major networks I want you to know about. So the mentalizing network has to do with theory of mind, or that is the same thing as saying thinking about thinking. It has to do with the ability to self-reflect. And I'll give you a little cute little 3-step thing in life that allows all of us to succeed. So it begins with, if I can self-reflect. So something happens to me. And so I'm wondering, well, what am I going to do with this? Well, if I can self-reflect, which means, hang on, what's going on with me right now? What am I thinking? What am I feeling? Where am I? And if it was me, I'd say, well, where am I in my brain? So if I can self-reflect, then I can self-regulate. Because you can't self-regulate until you know and have acknowledged, reflected on, what you're actually trying to regulate. You can't regulate nothing. So you have to be able to self-reflect first, which is this mentalizing network. The fancy term is theory of mind. Some of you know that. So it goes, if I can self-reflect, then I can self-regulate, calm myself down. And that's where most therapy comes in, is in the calming down, thinking about yourself stuff. And then, number 3, if I can self-regulate and calm myself down, then I can problem solve. Whatever it is that just happened to me, I can problem solve it. So when you think about driving down the white mud and suddenly some idiot comes and cuts you off, and you're like shaking because you almost had an accident, okay, what's happening to me right now? How am I feeling? Can I calm this down, take a few deep breaths, maybe pull off to the side or slow my car down, collect myself, and carry on down the white mud? And the problem solving is, I'm just not going to be anywhere near this guy because he drives like crazy. So that's one network. The mirroring network is about modeling. There's a really good book called Parenting from the Inside Out. Dr. Siegel in UCLA wrote this book, and he has a whole chapter on mirror neurons. And if you understand mirror neurons, your kids learn a lot by literally mirroring you. But it's a fascinating chapter if you ever wanted to read something really good about this mirroring network. The salience network affects things like ADHD, where if you have to decide, or your brain has to decide, what's really important in my environment. And how this gets hijacked in trauma is safety is always first. I need to know I'm safe. Whereas the rest of us can, I don't know, seek pleasure or seek learning or seek a relationship or whatever. Whereas if you've had trauma, you need to seek safety first. But the salience network it's about, typically it's where it shines is in ADHD, where the mom is called in from the kitchen to the living room, honey, it's supper time. And the kid says, yeah, Mom. 2 minutes later, honey, I said it was supper. Yeah, Mom, I'm coming. 5 times later, Mom marches into the room, puts the head up, makes eye contact. I told you it was supper time. Now get in the kitchen. And the kid looks up and says, okay, but why do you always yell at me? And the reason is because it went into the ear but did not go into the brain because it didn't reach salience. It didn't reach like, oh, hang on, this is actually a priority. I really ought to listen to Mom. So, salience is a network, and the executive network we all know about. It's impulse control, judgment, self-regulation, and more. So, this is what your brain looks like. This is each one of those colors of the lines is a neural network, and this is what you call the connectome. And the connectome also gets interfered with in trauma, but the connectome is like the genome. So we're understanding the genome, and we're mapping it out. We're also mapping the connectome, and that's just as important as the genome because it's how your brain works. And this is some nifty pictures. This is what your neural networks look like when they're all lit up. And this is how beautiful brains are. There's just these series of neural networks that if they were always raised in a safe environment, they work just fine. Looks like a mohawk, but you can see the base of the brain there and the blue going down the spine, and so you got a pretty good idea there, upper midbrain and lower brain. So, but here's what I want you to take from this. Whatever your relationship is with kids, you can affect all these 4 principal neural networks by anything that plugs into them. So this is the mentalizing network, and look what plugs into it. You can use imagination, memory, visual techniques, social techniques, emotional self-regulation, negative, which means negative consequences for negative behavior, so consequences, positive, affirmations, etc., attention, and I want to make a note about attention. Attention is necessary in the first 4 to 5, 6 years maybe, because that's what settles attachment. And kids will seek attention. When they're down their brain, they're going to look for attachment, but it'll come out as seeking attention. But we tend to deride that by, oh, they're just seeking attention. And we put that like, no, that doesn't count, bud. That's not going to fly. And yet, think about it. When you're down your brain, you go back to basic attachment, and you'll want attention. And then cognitive approaches, which is CBT and some mindfulness stuff. So you can plug into the mentalizing network in a whole bunch of different ways. It doesn't matter if you're teacher, parent, therapist, youth worker, etc. You can plug into the mentalizing network. And the same with the rest of them, the mirror neurons. Look in different ways you can plug in. Some bigger than others. So this is down your brain a bit. So big motor, big visual aspects, because this is 0 to 6 stuff, and they're mirroring us all the time. And then the salience network. How do we get things up to the top of a child's brain so we don't have to say it 6 times? These are some of the techniques you use. And this is the executive network, the thing we most want in kids so they'll sort of be able to manage themselves well. But look at all the different things you can do. So let's get on to trauma and how it actually works. And one of my favorite things is to quote Dr. John McCrae, who wrote the famous In Flanders Fields. He was a battlefield surgeon, but he was also a poet and a storyteller. So you all know In Flanders Field that we celebrate on November the 11th, but he had this quote, "When violence is afoot, it and its consequences are all that matter. No one thinks clearly." So, in trauma, you guys know, I think, that when your trauma is triggered, it's if you're reliving the same thing again. And if you have to disclose after a trauma, that in particular is reliving your trauma again. So, no one thinks clearly. And the justice system has to learn this because we base our justice system on motive and clarity. And so if someone, say a jury or a judge in a court, hears someone telling their story, but they're regressing down their brain as they tell the story because, after all, it's their trauma story, and they look like they're not quite all there. And, his quote is, "No one thinks clearly." But somebody else in the courtroom, who maybe has been on the stand, maybe the perpetrator, is thinking real clear. So the mistake a courtroom might make is, well, he seems really rational, you seem not rational, so guess who we're going to believe? And this is where trauma really interferes with society, because we then don't have a sense of fairness or justice around the responsibility for trauma. But it comes out of our brains and how our brains operate. So anyway, McCrae wrote a story about adult PSD, which is war. But we're going to talk about the story of children and developmental trauma. So in developmental trauma, the hardware, which is your brain and its circuitry, is deeply affected by the software, which is our experiences. So think of the brain like a computer, where you have the hardware and you hope for the best hardware you can get. But then the software comes with a virus. And it doesn't matter how good your hardware is, it's going to misdirect the hardware, this virus in the software, and your computer's going to go kaput. Right? So that's how I like to visualize software and hardware in the brain. So it's damaged or overwhelmed or rerouted in ways. And unfortunately, post-traumatic stress disorder is a chronic disorder. And I'll say in just a moment how developmental trauma is different than regular post-traumatic stress. So maybe I can bring up that slide. But first I want to talk about the amygdala. So the amygdala is, again, a cute little almond-shaped center in your midbrain, or in your limbic system, what we call the middle of the brain, the emotional brain. And what it does is, if something happens to you, it's supposed to direct it to other experiences we've had in life to help explain this. So, if you will, put this experience in context, right? Like, what is this, and what does it mean to my past, and what does it mean to how I'm supposed to respond? But after trauma, the amygdala gets hijacked by threat tracks. So in developmental trauma, the worst thing that happens is threat tracks get built into these big, massive neural tracks, and your self-soothing, self-calming, self-regulation tracks don't get the time and attention, so they're not built nearly as well. So it's a double whammy. Not only can you not calm yourself down at the best of times, your threat tracks are the ones that call for the experience that just happened to you. The amygdala hijacks it down your brain to your threat tracks, and what should have been a 2 out of 10 response to a 2 out of 10 event comes out as an 8 out of 10 response. And the rest of us are like, what? That was a small thing. Like, why did you have such a big response to that little tiny thing that just, your sister just said, A, B, or C to you? Like, why did you have a meltdown over that? Well, their amygdala got hijacked. Now, that's not necessarily going to help you in your kitchen, but you need to know that that's kind of what happens in the brain, is what was supposed to happen doesn't happen now. Repeated trauma resets the body's physiological functioning in the central nervous system to continually prepare for the next trauma. So just think of that. It's like concussions. You get one concussion, well, okay, you recover and you hope for the best. You get 2 concussions, oof, now your brain is a little bit fragile. You get 3 concussions, and you're probably going to get more. All you got to do is like fall over and hit against the wall, and you got your 4th concussion. So concussions are additive, but so is trauma. And every time you get trauma, it's easier to get the next trauma. And that explains why all the way into adulthood, trauma affects us in all kinds of ways. And when we get to the ACE scores, you'll understand that. But trauma can affect our cardiovascular system, our GI tract, our, especially in females, pelvic pain, and chronic multiple illnesses, and et cetera. We'll get a bit more to that when we get to ACE scores. So the diagnostic criteria for any post-traumatic stress disorder is these things. And you probably know this because you've worked with kids with post-traumatic stress disorder, but an event that one's life is, and safety is, integrity is at least perceived to be threatened or damaged, intense fear, horror, helplessness, continued re-experiencing, avoidance of triggers, memory gaps, and signs of persistent arousal, like you're always on edge. So any one of these things can cause quite difficult dysfunction, which means I can't operate properly. At school, at home, with my friends. But you take 4 or 5 of them, and a person can quite literally be a wreck. They can't function well at all. So, characteristics, though, of developmental trauma isn't, say, post-traumatic stress disorder happened because of a car accident or a mugging. It was one time involving strangers. It can cause a full-blown post-traumatic stress disorder, any of that, one-time big events. But the kids that we treat at CASA will have interpersonal victimization, where it's a caregiver that was involved versus a stranger, multiple traumatic events over several developmental periods. That's different than saying over some years. That's saying it happened in utero and in infancy and in the toddler years and in the preschool years. And each time you change developmental periods in a child, there's new brain function that was supposed to come on, new hardware comes on. Whereas an adult, if, say, they had trauma over 5 years, they're in the same developmental period over that time. So that's why kids are so much more at risk for trauma. So we want to name it something different. We call it developmental trauma disorder, sometimes called disorders of extreme stress, NOS, or DESNOS. You might see that in the writings, or just complex post-traumatic stress disorder. So, often all three. And here is what this complex post-traumatic interferes with in 6 major dimensions of functional maturation. And we're going to go into each of these. So let's take these one at a time. So regulation of affect and impulse. And here's how it can interfere with that. You have poor mood regulation. You have poor modulation of anger. I mean, any kid gets anger. You know, mild temper, moderate temper, severe temper. All that to me is normal. But a whole other ballpark is rage, when you've completely lost it. And parents and teachers especially have seen, and therapists have seen what rage looks like. Self-destructive impulses, suicidal preoccupation, these are particularly in our teen kids, but not always, unfortunately, sometimes in littler kids. Difficulty modulating sexual impulses or sexual involvement, which mostly, again, is our teen kids, and excessive risk-taking. So that's the first one. And altercations in attention and consciousness. There's amnesia, where we have these huge memory gaps. And you might know, maybe even from personal experience, what's it like to have memory gaps? It really bothers a person because you feel like part of you is missing. I can't place from my 5th birthday party to my 10th birthday party. I can't place that. Where did that go? That whole chunk of me is missing. So this is a big deal to people, including kids. And then transient dissociative episodes. And dissociation is this event where you literally kind of leave your body. It's kind of an out-of-the-body experience. And it's survival-based, so that if your body is really being hurt, like in war or that kind of thing, you kind of step outside and just kind of observe it. That's why, by the way, in car accidents, when you have a memory of a car accident, it all happens in slow motion. Gee, I remember the car coming, I remember the bang, I remember the glass breaking, I remember my head hitting the dashboard, I remember flipping back, I remember thinking, how's my kid doing? I remember the car rolling over, and you get all this stuff in slow motion. And the reason that happened is because you dissociated. No surprise. Now, kids dissociate a lot. And if you don't know that as a parent or teacher, they're going to look kind of dreamy, and they're going to say, I don't know. Especially if you think you're going to talk to them about this event in their upper brain, their cognitive brain. Because they ain't going to be there. They're way down their brain, in their sensory motor brain. And when you dissociate, it's a little bit like sleepwalking. You can still do stuff. Sleepwalkers can leave the house. They can unlock the door and leave the house, but they're still asleep. So can people who dissociate. I treat a little girl who has gone downtown on the LRT, completely dissociated. And we had to get the police to find her. She was looking for her birth mom. Her body said she was about 13 years old, or 12, I think. But she was about 2 when she dissociated, and she got on the LRT and went all the way, and this is like 2 in the morning, by the way. So you can imagine the parent was pretty upset about this. Depersonalization means you don't feel real. The world may be real, but you don't feel real. As if you're artificial somehow, or not yourself, somebody else. And then derealization is, no, I'm real. The world around me is not real. And these are vivid experiences people with trauma can have. And I would like to give you tonight an array of the things that go wrong. So if you know anybody who has trauma, or if you've had trauma yourself and some of these things happen, you can say, oh, well, okay, I can be somewhat self-compassionate or compassionate to the other, because there's so many things that can go wrong with trauma that we really need to be compassionate with this. So the next thing is alterations in self-perception. And you see at top, it says 2 to A to F. These are the DSM diagnostic criteria of how you actually arrive at a diagnosis. Sometimes you wonder, well, how do the doctors arrive at these? Well, this is how we arrive. It's a little bit of a menu. You have to have 2 of these and 3 of those and 1 of those, and you get the diagnosis, right? And P.S., DSM is not a Bible. It's just a guide for those of you who understand DSM. So alterations in self-perception. So we get, kids with trauma get these negative affirmations, like, I'm not good enough, I'll never be good enough, and I'm going to prove to you I'm not good enough. So they go ahead and try and prove it. So they get this sense of ineffectiveness, a sense of permanent damage. I had a girl once tell me, I'm garbage and I belong in the garbage can. And she was about 6. Guilt and responsibility. What's the commonest thing that kids feel when their parents divorce? It was my fault. If only I would have been a good boy. So guess what? If your mom is getting beat up, guess whose fault it was? If only I would have been a good boy. That's how kids think. Shame, especially cultural shame, and certain cultures are very prone to shame, and shame will block everything else. We don't talk about this. We just don't talk about it. My mom would never talk about anything. She'd say, no, that's barring your soul, and you don't bar your soul. Maybe that's why I'm a psychiatrist. I don't know. So nobody can or will understand, and that's what you'll face as a parent or a teacher or a therapist. Why are we doing this? You can't understand me anyway. Or I'm too damaged, so just, give up on this. And or the opposite, minimizing, which is unfortunately mostly males, but I'm fine, don't bother me, this hasn't bothered me, it's never going to bother me, so don't talk to me about this. Alterations in relationship with others, inability to trust, re-victimization. So again, the brain is set up to be hurt again. And then victimizing others, and this is where we get to transgenerational trauma, and our Aboriginal or Indigenous brothers and sisters, they know this well, but everybody knows this well. Transgenerational trauma is passed on in any family of any socioeconomic status, but in some cultures it's worse than others. Somatic effects of trauma, and there they are. Alterations in system of meaning. This is the spiritual part. Despair and hopelessness, which is the warning signs of depression and suicide, and the loss of previously sustained belief, the loss of any spiritual context or meaning. So what happens after we get developmental trauma or post-traumatic stress disorder? Well, here you go. 26 times more likely to have depression or other affective illnesses. 37 times more likely to have generalized anxiety disorder, i.e. meet the criteria for these things. And what I worry about is not enough healthcare practitioners have trauma as part of their history. So you may present with depression, but they forgot to ask about trauma. So they see you as a case of depression, and they didn't realize it grew out of post-traumatic stress disorder. And they missed the primary diagnosis in that sense. When we get to ACE scores ought to be a new vital sign, just like height, weight, blood pressure are vital signs. Your ACE score ought to be a vital sign. 28 times more likely to have panic disorder, 6 times more likely to have alcohol abuse. 80% of the kids with developmental trauma will have at least one other diagnosis, and 44% had 3 or more diagnoses, and those are most of the kids we see at CASA. We see the more, if you will, kind of complex cases. So, a little bit about attachment, because you can't talk about developmental trauma, and again, that's different than an adult car accident or even an adult abused person or whatever. They were maybe fine till they got to adulthood. But if a baby is born into an abusive situation, or poverty, or Just how many things can go wrong. It affects attachment. So here's what attachment is. Normal attachment is an organized, cascading neurodevelopmental pattern which establishes the foundation of all future experiences of self, which is bodily states, emotions, and self-regulation. So notice those are things we want to govern in kids. And all future relationships to others. Caregiving, comfort, safety, all the way up to adult partners. And why we choose partners that we do sometimes. So attachment requires appropriate parenting, which is 1, consistent nurturance, plus 2, predicted safety and structure. It's kind of the yin-yang of good parenting. When to structure and bring in boundaries, and when to nurture. We all do a reasonably good job of that, and there's a phrase, good enough. We do a good enough job of that. But if you're addicted to drugs or seriously depressed or being abused or et cetera, then parenting goes out the door and the child gets sometimes neither the nurturance or the predictable safety and structure, and they develop an attachment disorder. And so our TAG program at CASA says most of the kids we will get will have both, a serious attachment disorder and a serious developmental trauma disorder. So back to the neurobiology of the developing mind. Attachment is an experience-dependent thing. So again, you can have all the genes, good genes, bad genes, doesn't matter, but it depends on the environment they're in. And I could tell you some of the science of that literally one gene in this environment will produce this, but in a different environment will produce that. And in the brain, that's proteins and enzymes and things, neurotransmitters the brain operates on. And you're sort of welcome to, it's a fascinating study, but we know that the environment will dictate the outcome of genes. It's good to have good genes, obviously, but the environment will still, good genes and good environment, well, you're off and running, right? Experience activates specific neuronal connections, and we saw some of those in the pictures, creating new synapses, and this sets up appropriate boundaries. So what attachment really does is keep us safe because it builds in innate boundaries in life. And you all know what it's like if someone breaks a boundary. All the hair in the back of our neck goes up because we innately don't feel safe around someone who's breaking a boundary. But attachment sets down boundaries, so kids without proper attachment. So in the middle of trying to solve developmental trauma, we're also trying to solve attachment and get a brand new attachment figure for someone. And sometimes we're successful and sometimes we're not, just like any other branch of medicine. Some of the patients do well and some not so much. This is mostly right hemisphere stuff. So if you know the difference in right and left hemisphere, it's not the language of the left hemisphere that's the problem here. It's things like facial expression and perception of emotion, relational communication, and being able to read your environment. That's all right hemisphere stuff. So I want to give you a cute example of normal dyadic attunement. So we have states of attunement with our kids as a parent or a teacher or a therapist or whatever. How am I doing on time, by the way? Soon. Okay. Each cycle in this attunement, so here it goes. So you're attuned, and there's a disruption, and you repair the disruption, and you're back to attunement. And the reason it was worthwhile going through that cycle is because this attunement's slightly better than this attunement. So it's worthwhile. So here's a cute example. A mom has an 18-month-old daughter dancing on her lap. They're laughing and giggling and having a good old time. Mom has long hair. So the kid's laughing and giggling and reaches out, gives mom hair a big tug. Ow! So mom stops. Her face drops. Her body freezes. And the kid like, what happened? We were having such fun. Right? So what's the kid going to do? The kid starts crying, like, Mom, what happened here? What's wrong with you? They don't understand pain and all the rest of it, right? So mom, being a good mom, takes a few deep breaths, draws the baby in, pats her on the back, rocks back and forth, sings a lullaby, and within 30 seconds, everything is fine. So we had an attunement, a disruption, a repair to the disruption, and we're back to attuned, and this level of attunement is going to be slightly better than this level of attunement. What happens in children with developmental trauma is the repair never got done because of abuse, neglect, etc. So we really need parents that are healthy. So I'm going to flip through some of this. Oh, well, this is kind of important. So attachment allows us to have genuine feeling states that are tolerated within the dyad between a parent and a child, or between a teacher and a child, or between a therapist and a child. And if genuine feelings are not tolerated, then you develop all kinds of defense mechanisms against genuine feelings, and that's the stuff we don't like. Lying, stealing, conning, manipulating, all the defenses against actually feeling what you feel, and that's what we see in these trauma and attachment disorders. I want to give you a little scenario of, say a mom and a daughter are in a kitchen, and say it's a 12-year-old daughter and the mom, and they're having a rough moment, and they're arguing. So when you look in this room, there's any one of 4 stories that might be up. So the child will have a past story, say they do have a trauma history, but they also got a present story, say they're in grade 7 and they're experiencing junior high school for the first time and whatever. So is it the child's past story or the child's present story? And then the mom has her past story and her present story. So then someone has to figure out, well, which of those 4 stories are we actually arguing about? Because in most family arguments, it's going to be apples and oranges. You're not arguing about the same thing. You think you are, but you're not arguing about the same thing. You're apples and oranges arguing. And you got to figure out who got triggered into what part of their story, and then for each person, well, where are they in their brain? Which is why you ought to go to your corners, your own safe place, everybody relax and calm down, and we'll talk about this later. Okay, I'm getting close to being out of time. So I want to tell you a little bit about, here's the place. There's a place for healing. It's called playful, loving, accepting, curious, and empathic. So when you see kids with trauma, you got to be in this place yourself as a healthy parent, healthy teacher, healthy therapist, healthy youth worker, etc. And this is where we get these 4 stories in the same room problem. A studies. To cut to the chase, this fellow, Vincent Folletti, wanted to understand, he's an internist, by the way, he lives in San Diego, and the neat thing about San Diego is everybody in San Diego has a job, belongs to the same HMO. So if San Diego, say, has 2 million people or whatever they have, they all belong to this same HMO, so it's Kaiser Permanente, and they have this terrific database of everyone in San Diego who has a job. So they got this built-in database. So they want to do a study on what's the common factors in chronic disease. So as an internist, he was worried about cancer, heart disease, diabetes, chronic arthritis, immune system problems like MS, that sort of thing, right? And to cut to the chase again, you know what they found? It was childhood trauma. So for the big bad illnesses in our society, the commonality is adverse childhood events. And here's what some of them look like. So this study was 17,000 people, male, female. They all had jobs, or they wouldn't have been in the study, and they had some wealth, and they had some standing in society. And in fact, they were so worried about asking these people about their early childhood experiences. They had a psychologist or psychiatrist on call the entire 3 years of this study in case someone were to freak out or flip out or something if someone asked them about their early life. And most of the people in the study said, thank God somebody asked, because nobody's ever asked what happened to me when I was a kid. And they were very interested to see, well, how it impacted my health. And these are 50, 60, 70-year-old people. So here's the category of 10 ACEs. You can go to acescore.com, I think, or something like that, and then you can get your own ACE score. It's just Google it, ACE score, and you'll get your own ACE score. But here they are. You can tell tonight if you want. First three are physical, sexual, verbal abuse, or mental abuse, emotional abuse. The next two are physical and emotional neglect. And I think, working with these kids for some time, neglect is the hardest thing to treat because there's nothing to get your hands on. It was a terrifying void. I'm cold and nobody came. I'm in pain, nobody came. My diaper's been wet for 2 days, nobody came. And that affects the brain dramatically. So, other things were a parent with addiction or other mental health disease, witnessing a mother who experienced abuse, and we talked about that, losing a parent to abandonment, divorce, or death. And that doesn't mean that there was a divorce and maybe you get to grow up with both parents. That's the healthy part. Some divorces can be quite healthy. But it's when you actually lose a parent or then a family member in jail. And this is a U.S. study, and jail is very common in the U.S. They jail more people than anybody else in the world. But not included, which is important to us here, is foster care and homelessness, which probably ought to be ACE scores. This is what ACE looks like. Adverse childhood experiences get into disrupted neurodevelopmental experiences, which we've talked about, social, cognitive, and emotional impairments, adoption of health risk behaviors because of that, because if you don't tolerate your genuine feelings, you turn to other things. Can't read it. Disease, disability, and social problems, then early death. And there's one slide here. Well, this is, if your ACE scores are 0, you get this much smoking, and if you get 6, it's 18%, and we go through a number of different things. Adult alcoholism, 3% of anybody gets alcoholism, but 4 and more ACE scores, you get 16%. Same thing with intravenous drug use. If you go to East Vancouver and ask the heroin addicts when they started drugs, you know what they'll tell you? Grade 3 or 4. That's when I started stealing my parents' cigarettes. By grade 7, they're doing pot, and by grade 10, they're doing whatever, and before you know it, they're in East Vancouver doing heroin. So life expectancy is cut short by almost 20 years, and that's any cause of death if you've got a high enough, like 6 for your ACE score. So adult doctors see developmental trauma, but just wrapped in big bodies with lots of disease. And that's the outcome of developmental trauma if we don't take good care of it in kids and give them some mechanisms to. So in summary, it's common, it's serious, it affects children and adults. We need to know about the developmental tracks, where kids are in their brains, upper brain, midbrain, lower brain, and then the things we've talked about so far will direct you in what to do. So if you're a parent, it'll direct you what to do. If you're a teacher, it'll direct you what to do. If you're a therapist, it'll direct you what to do, etc. But you need to know the basic underlying science of it. So hopefully that's what we've gone through tonight. And then when we get to the panel, we'll talk more about the specifics that you folks have and maybe more specifics about treatment itself. So thank you very much for listening.
Wow. Dr. Andrew Bremness. I'd like for you to sit in, actually, if you could sit in the middle, because you're going to be the center here. Boy, I wish I had known some of this when I had kids. And I have to admit, I had a bit of a minor fantasy as I was sitting there knowing that we were all going through all of our stories from our childhood and our upbringing and the things that we've dealt with in our family. Wishing, boy, wouldn't it be great to have a hologram of Dr. Bremness up there somewhere to go to for advice to let us know what those family arguments are about. CASA. So one of the things that we really value at CASA is looking at the lived experiences as well. So we've looked at the brain development and the science behind it, and now we're going to talk to people who've actually experienced trauma in different ways, and then look at this from another perspective as well, from a physical perspective. So we're very pleased to begin with Cassandra Waldbauer. Did I say that right? Waldbauer. She's going to be the first to join us on the panel this evening. She graduated this spring with a degree in psychology, and she's actually now studying to be a social worker. She's a member of the CASA Youth Council, which is a fantastic organization, and she's co-chair of the Council's Community Education Subcommittee. Cassandra has experienced trauma on a personal level, with also with a family member as a caregiver and on a family as a family member. And so we're just so grateful that you have joined us on the panel this evening. Thank you so much.
Thank you for having me.
Okay. So I guess we want to get an understanding of what your perspective is, where you come from, what your story is. Because when trauma really started for you, you hid it. You didn't talk about it for a long, long time. Where did that begin?
Well,
Yeah.
when I was young, there wasn't any information being talked about mental illness or mental health, especially in the school setting. So when I started experiencing symptoms of anxiety and depression, I really didn't know what to do with it. So it was a difficult time because it was hiding it from a lot of my family, and surrounding myself with people who were going through the same things, but definitely didn't help with the coping or with the healthy ways of dealing with those symptoms. And then as those progressed and I fell into even worse friend groups and things like that, being surrounded by people who weren't helping at all, I experienced sexual assault and things like that, that just really it was a really big down spiral for me. And I think the turning point, I remember having a fight with my parents in the living room, and all I wanted was for someone to hear me, and all I wanted was for them to listen. And I really wanted to be homeschooled because I didn't want to go out into the world. I didn't want to deal with anybody. And I remember having a fight and them not listening at all, and me just lifting up my sleeve and sharing my sorrow and saying, I am not a normal kid. I am not dealing with the normal things. Please help me. And that was the biggest turning point for me, because after that, I knew I couldn't live like that anymore. I couldn't live hiding myself anymore. And it's brought me, to volunteer opportunities like this, where I can come in and talk about these things and talk about turning points and hopefully bring awareness to other people about what others are going through, and hopefully, just let people know that just because someone is acting out or not telling you certain things, that they're not just being a typical teenager, they're going through something much worse.
You've been kind of honing your skills in this area too to help others. You're studying social work, but you also helped your brother-in-law.
Yeah, recently, a few years ago now, my brother-in-law fell into a not so great path and became addicted to really hardcore drugs. And so in my part of that is that I obviously see myself as family, but I also see myself as an outsider. So I've been a really big, objective person for people to go to. And even with him, he still comes to me as the only person that he can talk to in the family, because I am outside of the family and I can take myself out of, that anger and sadness for him and work with him instead of, just getting mad at him, reprimanding him.
Things that you wish someone had done for you.
Exactly, yeah.
I know this is simplifying things because we don't have as much time as we would like to really delve, but what was the impact on your family?
With my brother-in-law?
Yeah. With your brother-in-law, with you, what's how does that impact the family?
It was difficult. There was a really big divide. Some of the family, at least in regards to me, some of the family didn't really believe that anything was going on, that it was just all in my head kind of thing. And the other half of the family was extremely supportive, came for all of the therapies, appointments, and helping with medication and everything like that. In regards to my brother, very, very much the same. It was very divided, and it's difficult because, especially in regards to my brother-in-law, I'm not the expert in that situation. He is, so I can't go in and say like, this is what he's going through, you know, this is how he feels, because I don't know per se. I might understand it more than another person, but I'm not the expert in that situation. So.
Isn't she amazing?
Yes.
One of the things that, you've learned so many things with the experiences you've had. What's the one thing you wish that could have been different, that would have really helped you progress more quickly?
I guess two things. The piece about believing when someone is in pain. I think often where it's easy to believe when someone is hurt, if they have a broken leg or they have a serious illness, like a serious physical illness. But when it's, in your head, as they say, it's much easier to just brush off. It's much easier to just say, okay, well, they've got to deal with it, it's their own problem. Or, maybe they should just change something in their life and they'll get over it. And the other thing is just, I want people to know that you have to listen. If someone is reaching out to you, or if you notice that their behavior is changing, reach out, ask them if they're okay, make sure that, even the people who seem the strongest are not. I know it's cliche to say that, but it's definitely true.
Okay, we're going to come back to some of these themes. As a parent, this next story really hit me. Because as a parent, your main priority is keeping your children safe. So you can only imagine the depth and the difficulty of losing a child to suicide. Betty Wedman lost her 17-year-old son, Alex, after enduring years of bullying. That was 11 years ago, and she has since become a very strong advocate for education and awareness and changing the system. Betty is a certified health and wellness life coach. She did all of these things afterwards. She has trained in cognitive behavior and applied suicide intervention, and she was part of the Edmonton Suicide Prevention Strategy. She's a member of the CASA Family Advisory Council as well. Thank you so much for being here, Betty. Is it? Okay. Tell us a bit about what led to your trauma, the trauma with your son that led to the trauma that happened in your life.
Well, my son chose to end his life in 2008, which is 11 years ago. He had been bullied. Take mine. He had been bullied in school. We were aware of it. We brought it to the school's attention, but I personally feel that nothing was really done with it. We took him to a psychologist to deal with the bullying. The psychologist wrote a letter to the school board indicating that he was suffering severe depression, and that by remaining in the school that he was, it would represent significant risk factor to his well-being to learn and his emotional well-being. He had several incidences of being physically harmed. He received a knee to his spine in a phys ed class, and he got an 8-centimeter blood clot to his testicle. We took him to the doctor, which then told us to go to the stollery. They examined him, and they basically just looked at the physical aspect, but they didn't look at what it did to him emotionally or mentally. He did, like I said, he did suffer with depression.
You were kind of blindsided by all of this. You didn't really understand the extent until that incident happened.
Absolutely, yeah. You learn as you go through this, and you experience tragedy, you want to help others. And that's kind of what my mission is now. Shortly after his passing, the kids in school organized a suicide awareness day. They were the ones that wanted to talk about this. A week after his funeral, my son had asked if he could have a party, which we had 45 youth in our home. Kids started coming up to me and telling me about their experiences of being bullied, what they felt, the hopelessness, the loneliness, how they had to change their personality to fit in. And I thought, how could you be happy if you can't be yourself?
You were a bit surprised though by
Oh.
okay, you were a bit surprised by the extent, because you didn't really, I mean, this was not something that was on your radar. As a lot of parents don't, I know my kid was bullied. I didn't know exactly what was going on. I knew something was wrong, but I didn't know.
Yeah.
So there's,
We really don't know the full extent. I mean, because what I have learned is that my son didn't really confide everything in me. But when these kids came to me, they actually told me they could not bring it to tell their parents because they were ashamed. They were concerned that they weren't popular in school. And I'm sure my son had felt the same way. And yeah, like I said, I learned a lot. It's been difficult, but I hope that through all of the tragedy we've gone through, we can make changes.
so I want to talk a little bit later about some of the stories that you've learned, but in the meantime, I think in many ways this has given you a purpose as well, where you've taken a tragedy and you've turned it into something where you're out. It's given you a new meaning in life.
Absolutely. Yeah. I was always very shy myself, and the first time they asked me to speak in a school in front of 1,200 kids, as I mentioned to you, Leslie, I stood up and I can just feel myself shaking, but I knew I had to do it to help others. Yeah, and it changes you. You're never the same person.
You have a lot of educators in the audience, and you know that sometimes it's frustrating dealing with people understanding, you know, what was going through with your son. You're a parent, you want to help your son. Do you have any pieces of advice?
Yes. I want everybody to be aware that you really do need to listen, that when kids come to you, that they're being bullied, that it is happening, not to brush it under the carpet. It was very hurtful for me to hear the principal tell me that boys will be boys and that physical aggression is okay, and it's not. We need to change that in our society. We need to be kinder to each other. So, yeah.
Okay, we're going to come back to this. Whoa. Our final panelist is Gail Bryant, and she's an occupational therapist, and for many years she was the clinical lead of the trauma clinic at CASA, working with children and families of children who have survived physical, sexual, or psychological trauma. This fall, she moved over to the education side, teaching what she has learned. Wow, that's exciting. Teaching what she has learned as the assistant teaching professor at the University of Alberta in the Faculty of Rehabilitation Medicine. Welcome.
Thank you.
Oh, we're so happy to have you here.
And thank you for sharing. It's
Yeah.
a delight to share the panel with you guys. Thanks for sharing.
So, the first question I asked you, and I'm
OT.
going to ask you again, but what does OT have to do with trauma?
So at CASA, mental health therapists come from all sorts of backgrounds. So there's psychologists, social workers, OTs, there's nurses, there's all the groceries. And occupational therapy is nestled within rehabilitation medicine. And so when we think about rehab, what often culminates in our mind is physical rehab, right? So for example, if we've had a stroke and we lose function in our hand, an OT wants to know about all the neurological pathways leading up to our brain, the sensory pathways and the motor pathways that help us function. And function gives us identity, right? It allows us to do our grooming and function in the world and write a text message. So function is really, really important. And the tenets in physical therapy are very similar in mental therapy. just like Dr. Bremness was saying, we need to know what's going on underneath the skin, right? The neurological pathways. Dr. B talked about 2 pathways, motor pathways, sensory pathways, but those are all informed by our neurological system, and everybody is at the mercy of your neurological system. So the challenge in trauma is that, like Dr. B was saying, our threat tracks are so much more beefier. They're bigger than our home tracks. And so our brain gets hijacked. And sometimes the symptoms of trauma can be very, very isolating. So now I'm teaching those things that I've learned.
Wow. Tell me a bit about the clinic.
Yeah. So the trauma clinic has evolved. Dr. B has seen it grow into this beautiful thing. The trauma clinic, we see families that children have had early developmental trauma. And when we say family, we're very loose with that term. Family can mean a lot of things. So it could mean your biological family, it could be a kinship family, like a grandparent taking over, auntie, tio, I'm just saying other languages for the same thing. It could be an adoption family. But we see families that young people have experienced developmental trauma or PTSD, but chronically developmental trauma, and often it's intertwined with an attachment. So there's often a breakdown in attachment, and lots of boundary violations or issues can come out after. So we see a lot of young kids that have experienced that and come for therapy individually, but we also have a trauma and attachment group, which I think Dr. B talked a little bit about, where we see families as a group, and there's something beautiful that happens with that lived experience, that empowering moment where you can connect and share your story, and as you're doing that, there's a lot of silent head nodding because people get it, right? And of course there's facilitators, but there's this lived experience connection, because trauma can be very, very isolating. The symptoms can make you feel very, very isolated.
It's interesting that no one story, there's no one story, there are multiple stories and multiple threads that are woven in different ways. So, you know, there's not one thing that fits all.
No, and I think a piece that stuck out to me in the presentation today is that biopsychosocial spiritual. Because even though we're talking about pathways, and that's pretty boring because we're talking about the neurons, I know you like to nerd out, Dr. B, but there's a human connected to those neurons too, right? And that's why I like that biopsychosocial spiritual, because trauma really can rob you of that, and that sense of meaning and purposefulness. And so for every child and family, it's going to be very nuanced because there's specific, we talk a lot about triggers. So when our flight tracks, those start to vibrate and we get frightened, everybody's triggers are going to look a little bit different. So our interventions are going to be very nuanced to that family as well. You're right, they're so diverse, the experiences.
I kept looking to you because some of the things that were coming up in the presentation, I thought, wow, what is that bringing up for you?
I think it's similar. The thing that stuck out to me most is, like, we talk about neurons, and we talk about all the different ways, all the different pathways that the brain makes. It's so easy, I think, to forget that, like, there's a child attached to those pathways, so, or, you know, a youth or an adult or anything like that, and there's a person. So, yeah, it was interesting. The biopsychosocial spiritual really brings you back and reminds you that there's someone there, and that the trauma is affecting someone. It's not just the brain.
Yeah. One of the things that we talked about is the two of you work a lot together, and that you work, you said from the top down, and you work sort of from the bottom up, the mental, the physical.
Yes, so when we say bottom up, we're thinking about sort of the tracks of our brain that help regulate. So we talked a lot about how our threat tracks can be vibrating when we're triggered, right? Because that triggering experience has created this cyclical loop in our brain that has, is that me or is that you, Leslie?
That's me.
Oh, Leslie.
I know.
And so what we want to do is interrupt that cycle with interventions that are often sensory and motor in nature. So calming, we want to work out, just like we would rehabbing someone who's had a stroke, we want to work out and exercise those calming tracks because they're much weaker, right? And so if we practice that daily, and those are archetypes of interventions that are the bottom up. They're not a lot of talk therapy. And remember, a lot of the kids that we're seeing, some of their trauma has been when they're quite young. So they don't have the language associated. So we have the trauma is often stored within the body. And that's kind of where we need to target it, is in the body.
Leslie, sorry to interrupt, but it's like a talking stick.
I know.
Betty has the active mic, so if we could just use Betty's.
Oh,
It's not
okay.
being recorded otherwise.
Okay,
So
here.
It's a talking stick.
Okay, yeah, passing the baton. Just a few things.
Was there, I was thinking during the presentation about your son and going through the trauma with having the bullying and the inability to articulate what was happening with him. I wonder what was going through your mind. The microphone works, doesn't it?
Does this one work?
This is the one that's recording.
Actually, I felt helpless because they tell you this, but as a mother, you still don't know what to do. You don't know how to stop the bullying. You think you're taking the right steps by going to the school and taking him to a psychologist to deal with it, but still nothing. I don't want to say nothing being done because that wouldn't be accurate. Because I think you have to be open and receptive to help, and maybe he wasn't ready for that. I mean, I really don't know. For me, I just hope that everybody is open to listening, to making changes, and to helping each other and supporting each other.
Yeah, I think something that you're speaking to is stigma a little, like where sometimes it's hard to take that first step to access help. And I think that there can be a lot of barriers socially, culturally, and I think that's why we have discussions like this, so that we can start breaking down some of those barriers of stigma, and the idea of wanting to be listened to and heard. I think it's such an important component when you're trying to access support or get some help, when it's there for you, right?
This is the talking stick.
I know. Why was it so important for you to go into teaching, to go into the teaching side? What do you want people to know?
Oh yes, talking stick. Bring back the leg. I think one of the pieces that I really wanted to go to teaching was this shifting the discourse. I think sometimes when a child or a person is really struggling, we often say, "What's wrong with you?" And I think the shift for me is really about, what happened to you to create this. And we talked earlier today about some of the things that can happen in our schools. Bullies are happening, and there's traumas that are perpetuating. And I really worry about the victims of those experiences, but I also am worried about the bullies too. And I think that the conversation needs to go to entry-level clinicians that are accessing education to support new clinicians in thinking this way and shifting the discourse. I think that's really, really important. And the reason why I wanted to go into teaching is to create kind of a supporting, trauma-informed system where we can help people and actually help them, not just have the services there, but make them accessible and available by changing the discourse.
Are things really changing?
I think in the last couple decades, I've been working here at CASA for about 10 years. I think the shift is happening around, the change for me is seeing that it's not about pulling up your bootstraps anymore and muscling through, and what's the saying, what doesn't kill you makes you stronger? And that time heals all wounds. I think we're shifting from that. And I think we're going to a place where we're looking at this as brain injury. It's something that's happened. It's not brain damage because we're banking on neuroplasticity, but it's an injury to the brain that's perpetuated. So I do see shifts and changes, but like Betty and I were talking before, there's a long way to go still. There's still work to do.
There's an equation that says when bullying is going on, there's the bully, the bullied, who's the victim in that sense, and then there's all the bystanders. And the bystanders probably are the most important part of that equation. So those are the people we have to reach so that they then also tell the school counselors or the phys ed teacher or whatever, no, that was a really important thing that just happened. I know this guy, and that was not to be played down. That was actually a really important event. So it's the bystanders we have to reach when it comes to bullying. And I think there's some wonderful educational programs right now happening in schools about that you can't be a neutral bystander anymore. You have to make a stand. The Me Too movement is a little bit of an example of that in adult life, where you make a stand and you call somebody out, and we may think, well, gee, it goes too far sometimes or not far enough sometimes, but we've got to make a stand. There was a fellow in town here who started a movement called, Call Them Out. So he was a black gentleman who would get racial, make it awkward, right? So you call people out, and we have to be brave to that, right? We have to be a certain kind of like you developed a strength out of the most terrible situation, but you developed a strength. So how do we get other people to develop that strength without something terrible having to happen, right? And so that's what I think we should talk about in the schools regarding this issue of bullying as one of the main, and then there's, of course, social bullying, which is even more difficult than out front, interpersonal bullying, because it's happening behind closed doors and no one knows until, it gets published in a paper or it gets published in, on Facebook or whatever. But social bullying is just a really trendy thing to do, and it's just as damaging as out front physical bullying, right?
Does it make a difference to the impact of trauma if you call people out, if you have open discussions, if you do something like what we're doing here today and you are open about it? Does that help to change the effects of the trauma?
Well, if I could answer one of your previous questions, I think there's a lot that's changed. I've been 40 some odd years in medicine, and I think medicine itself is more trauma informed. Still lots to go, but more trauma informed. I think society is more trauma informed. And the fact that something like the Me Too movement took off, and really the idea was that when people say they've been abused, they've been abused. It's not, oh, this person is whatever. And maybe there's some of that we need to pull back from a bit, but the principle is correct. So I think people are a bit more attuned now to calling people out, and maybe it'll get down to the kids. And I think, this lovely teenager Greta from Sweden is calling out the world on climate change, and people are listening. I mean, even the president's tweeting about it, and not positively, unfortunately, but at least it draws some attention that there's this single teenager who's calling us all out on climate change. So I think people are just getting better at that. And I would hope it gets down to calling out the source of trauma. So the source of trauma in this case is bullies at school. And the teachers and the school counselors and the success coaches at school understand that now, I think more than ever before. But what we have to get to now is the trauma that happens in developmental trauma, when we see kids at 6 who have 6 ACE scores by the time they're 6 years old, right? So we need to call out, ineffective, abusive, neglectful parenting before it gets out of hand. And this is a huge problem for the Department of Social Services, because on the one hand, they're mandated to keep kids in families, and on the other hand, they've got to protect the kids. So it's a big dilemma in society about how we go about protecting kids and keeping them in their families and helping parents who sometimes want the help and other times not so much. They don't want the help, and then we've got a pretty sticky problem.
Betty, you talked about the golden rule. Tell us a bit about that, why that's such a big deal for you.
Well, for me, it was because after when I had mentioned that my oldest son wanted to have a party, and we had 45 youth in our home, and we had 15 of my oldest son's friends, and 15 of my son who passed, and 15 of my daughter's friends. And that night, kids came to me and had told me that they had been bullied, and I asked them if they would share with me, and they told me not tonight because we want to honor your son. But they did come back, and they explained to me about the trauma they faced in bullying and how they had to strategically plan their way around the school and the places these kids were least likely to be. And I really think it's how we treat each other, and that is something that I've been going into schools and talking about, is to treat people the way you want to be treated. And I really think bullying can be stopped, or at least lessened. And the trauma, it does affect everybody, because not only did my son and these kids experience trauma, but I call it the ripple effect. It affected me, it affected my family. Sorry. Sorry, Leslie, but when I came home from work, I turned the corner and I saw nothing but police cars, fire trucks, ambulance, coroner. I'm sure there was at least 10 emergency vehicles in front of my home. And I knew something horrible had happened. And when we talk about the effects, I just remember driving down Calgary Trail, and I was sitting at a set of lights, and behind me was an ambulance. And of course they got called, and that siren came on. And I can't even tell you what it did to me. And I understand trauma, because you shake so bad, you don't even know what to do. And then I get why people honk their horn and say, what's wrong with that person? I really do. Like now when I'm in traffic, I totally get it, because we don't know what anybody has been through, what they've suffered, I really believe that each one of us has had something tragic happen in their lives. And I know that by talking in schools, because I do. I know, Leslie, you asked me what changes a choice is. And I just ask a lot of questions, and I start off just with asking if you've ever been told you're a bad kid, and go to things like if you've been called stupid and loser and gay and fag, and I go to the mental health and how many people are affected by somebody that they love that's alcoholism, drug addiction. And before you know it, there isn't one person in the room that doesn't stand. And we're all affected by something. It's just that we don't talk about it. And I think by just seeing all the people in the room today, I applaud you, because I know this is how we make change.
Mm-hmm. Yeah. Good idea.
You bring up a really good point, Betty, or it reminds me of a good point that everybody on the panel said. We need to talk about parent shaming. I mean, when we talk about what kids go through, I mean, if you look at the stats, a lot of abuse happens in the home and that kind of thing. A lot of trauma happens in the home. But you said you felt, sort of guilty. You didn't see all the signs. But it's really important not to blame.
Right. Yes, please.
I want to stress the importance of talking about this, and not only that, but it wasn't until after that I experienced all this in my life that I took the applied suicide course. And, we take CPR to save a life, as you mentioned, to somebody who has heart problems. And why don't we educate ourselves with mental health? I just think that if I could have asked my son more questions, there could have been a different outcome. and that's the part of the shame and the guilt. It's like, I'm the mother, I should have done more, I should have did more to protect him, and yeah.
As a society, are we oblivious? Are we really, is that what you see? Are we oblivious to this?
Well, one of my slides, at the beginning of the ACE, there was a person who wrote a book called, Alice Walker wrote the book called Possessing Joy. And she wrote about how childhood trauma is like a taboo subject that we're not supposed to talk about. And so possessing joy has to do with getting past that and getting into genuine feelings. And on the other side of dealing with difficult, genuine feelings is, in fact, some joy in life. So we need to get there. But, it's human nature not to want to talk about the yucky stuff in life, right? So don't talk to me about that. But if we can start with the dyad and help newborn moms and dads, just as important for dads, and aunties and grandparents and everyone else is in our orbit, because we attach to 3 or 4 main figures in our lives, that we can share genuine feelings in that dyadic experience and be accepted unconditionally. I still love you and you're angry, or I still love you and you're sad, or I still love you and you're happy and joyful, and that's the easy bit, of course. And so, in our offices, the slides are about the understanding from which you then can do things in your office, or do things as a parent, or do things as a school counselor or a therapist. You just need to know, and when you do the suicide intervention training or study social work, you learn a slice of the pie. Like, I know a slice of the pie, but that's all. And so we need to have each other remind what the other slices of the pie are like. But if we can get that all into the original dyadic experience of growing up healthy and dealing with genuine feelings, so when we do get bullied, or we do get depressed, or this or that, there's a mechanism in which to deal with it, and that begins with a healthy family. So that's why in CASA's mission statement, it's child, adolescent, and family mental health.
So
right?
what are some of the things the two of you have learned that work?
You looking at me, or you want the stick?
Okay. I think the dyadic piece is really, really vital. And it actually comes on a nonverbal level, just being with, right? We talk a lot about being with on our teams, just being present with someone. It doesn't have to be a very verbal thing. So we do a lot of support between dyads. I think the other piece for me that stands out is honing in on something we haven't actually talked about is resiliency factors. And what I've learned over the years is resiliency is not one thing. It could be, your genetics or temperament for sure, but it could be your interests and your values as a family. We have young kids that are amazing artists, athletes. They're really, really interested in a topic, and it's taking the trajectory of their life and their identity in a different direction. But it also can be, resiliency can be people in your life, family members. It could be a social worker, a big brother, big sister. It could be a teacher. It could be your doctor. It could be a therapist, someone that really sees you and really wants to champion you because they see how amazing you are. And if we can see that at the dyad level and look at resiliency factors, and I think that's why we're all here, is to support and hone in on people that need support and identify what their resiliency factors. And just listening to both of your stories, there are pieces of resiliency that stick out for me in both of them.
Let's go around the room. What you've learned. What's worked for you? How you developed that resiliency? How you've been able to get to a point where you turned a negative into a positive?
Well, obviously, from the loss of my own child, just knowing that I had to do something to help others, and then to knowing that my own children's friends were hurting as well and were suicidal. I know on your slide screen show, we talk about some of the things that we have to do, and it was for self-care. The cognitive behavior I took, that helped me even immensely for myself. And it's really about how we think, how, as you said, Dr. Bremness, how we think and how we feel. It's all about our behavior. Positive affirmations help me. Even when I talked about, being stuck behind the ambulance and the anxiety that it caused, I had to take myself to a place that instead of going to the tragedy, to remember that these people are going to help somebody and to turn that story around. You just keep finding things that work, and sometimes you have to try many different things.
Thank you. So, a few comments. I mentioned this little formula for life, like if I can self-reflect, which just means ask the basic question like, how am I doing here and what's going on with me? Yeah. And then from there I can self-regulate, and then that's where people come in to help you. So that's where most therapies, CBT or mindfulness, or you guys may know, there's 250 registered different kinds of therapy. But in these 3 little questions in this formula for life, they're all in there someplace. So if I can self-reflect, then I can self-regulate, and if I can self-regulate, then I can problem solve. So eventually you self-regulated, got out of the way of that ambulance or whatever, and life carried on. And the more we learn these 3 steps, and maybe it includes therapy, maybe it includes meds, maybe it includes supports at school or the right IPP at school or accommodations and all kinds of things. That's the biopsychosocial, educational, spiritual view to a treatment plan. Then we can really move forward. And it takes the village, right? And that's a common phrase. The part of the village that I spend a lot of time in my office doing is the care of the adult. So if I'm seeing a parent whose child has suffered trauma, and they're taking the brunt of all the things that can go wrong on these slides, etc., and all the different ways kids express themselves, that mom needs as much help as the child, so they can in fact be the proper parent for that child. So we're always looking for good self-care from the parents, right? And so we're calling up, support agencies in the community, FSCD and others, that there's all kinds of agencies out there that can supply parents with help and mindfulness and some actual sort of hands-on, like, okay, we'll come in and take care of the house because you can't do that right now, and then once you get back on your feet, then we can, you can parent your kids or just focus on your kids. So all parts of society have a part to play in this, because the dyad is the most important thing, but it includes the parent and the child, or at school, the teacher and the child, and in therapy, the therapist and the child, and then the bus driver and the child, and all the adults in those categories, they have to get good self-care. So they see their therapist or their doctors, or have a good priest or counselor, or just good pal, good friend who helps them through. And the word champion came up, and we all need a champion in our lives. So the kid needs a champion at school who's going to see them through that experience, because we're not there, right? It could be the janitor for all I care, but someone is going to see them through their school experience. The parent needs a champion who's championing their cause to be a good parent for this kid. And that's what a lot of parents miss out on. They don't get the supports they need to be the good parent for that kid. Sometimes we don't even know what's going on. But we treat mostly parents who knew the child had a lot of trauma, but they're the one who get the brunt of the symptoms. And so they need a lot of supports, right? And so do school teachers and therapists.
What's your reaction?
What works?
I relate a lot to the 3 steps for life. It took a long time for me to be able to do deep self-reflection. And like I said, that turning point in my life, I had already done a little bit of it, but not a whole lot. And going into therapy and going on medication and things like that really made me think about how I know what I know and where I got all that knowledge. And so, I really, those 3 steps really resonated with me, because even in situations now, I try and take myself out of them. I reflect on what's going on, how I'm feeling, what I'm thinking, why am I thinking that? Why am I feeling that? And then I go into an action phase. So it's not just straight action, because if I act out of my feelings, then it's often anger or, anything like that. Another thing that worked for me was that I clung to my mom. She's like
A
my
strong diet.
yeah, exactly. She's like my biggest support, and I clung to her for everything. So she's her and, the one good friend that I had in that situation, who turned out to be my fiance now. Those two are my biggest supports, and they always will be. So.
Wow. I'm so impressed with you. I'm always curious about, 100 people want to do something, but one person is able to take it and turn it into something extraordinary, and I think you're one of those people. And I'm listening to you going, okay, what is it about you that you've been able to overcome and get to the point that you're at that others haven't? I don't know who has the answer to that. You've been listening.
I have no idea.
What are you doing differently?
Well, can I just say that very likely you've got good genes, and very likely you had a good dyad that you could bank on. You developed friendships. You're going to marry one of them, apparently. And you had enough wherewithal to stand up to your parents and say, I'm not the average kid on the block. I really do need help. You can't just ignore this. So that's resilience in a nutshell, all of that. It's various levels, and then you learned your 3 steps to life, right? And so that's what it is. It's doing all that, and you had a champion. It was your mom, right? Got a new champion in your fiance, hopefully. And but that's what it is. It's generation to generation to generation, and we keep passing this stuff on. So if we can pass on transgenerational trauma, we can pass on transgeneration resilience. And that's what I think happened here.
Wow. Okay, yes, thank you. We have a number of different areas that we can cover, but I think we're at a point where I'm not sure where, generally we get people here who are in the education area, people who are in social work, we get families, and we'd like to get an idea of what you would like to hear about. Is there, what questions you might have for the panel? We'll have a chance afterwards, after this is over, for you to talk to people individually if you want to share your stories or you're looking for, something a bit longer than a question. But we'd really like to hear from you. What would you like to know?
Hi there. So we've been hearing a little bit or a lot about sort of the mind-body connection, say ACE's implication on, say, long-term immunity and those types of things. Mm-hmm. I'm wondering about some of this emerging discussion around the reverse of that, the body's impact on our mind, and say this discussion around the gut being the second brain and neurotransmitters being often generated there, or mitochondrial dysfunction and disease and its impact on our brain, and therefore our ability to, say, process some of these events and exercise, say, in BDNF and all those types of things.
Right.
I'm just wondering where we're at with sort of some of those interventions as an adjunct to some of what's been discussed about already.
Should I jump into that? Well, first of all, you're absolutely correct. Mind-body is both directions, right? The highway goes both ways. And when I spoke and when Gayla spoke about the sensory motor brain, that's where all that comes in. So I think my mic works from here, so thank you. So exercise. I mean, everyone who comes in my office is generally on an exercise program, vitamin D, because we live north of the 49th parallel, omegas, because they're good brain food. They don't necessarily cure any disease, but they're good brain food. And then maybe all of the kids should be on probiotics or something that helps stabilize the gut biodome. There's this huge nerve that runs from the brain to the gut called the vagus nerve, and we know it goes both directions. So when we speak in terms of, I could feel in my guts, Well, in fact, since the beginning of mankind, we've known that's our second brain, right? Because we feel it in our guts. And this is all wonderful emerging work. We're not sure exactly where it's going to lead, but absolutely everything you just suggested in whether we call it chronic fatigue or the things that affect adults that we didn't know anything about and poo-pooed for the longest time. We're getting to have a much broader view of what bottom-up actually means. And so the gut biodome is something we need to pay attention to, right? And so I just want to say kudos for bringing that up, and that everyone ought to be on an exercise, because we know exercise improves the immune system, tolerance to depression, tolerance to anxiety. It's probably part of resilience. So yeah, let's all have good diets and good exercise and good bugs in our guts, right? So all that's important. And that's why when we say biopsychosocial spiritual, we mean all the nuts and bolts of biology, including exercise, right? And good food. I hope that addresses the... Well, boy, we're having trouble getting that into the adult world, right? So, I go back to basics. Is there a hot lunch program in the school, and are they serving good food? And are there junk machines in the school, and are they getting the Twinkies out of the school? That's just some of the basics that I try and talk to schools about, right? But we're getting better at exercise, and every kid has to have gym, and every kid hopefully gets a chance to go in a sports program, and and for those who don't like exercise, well, we just got to figure out other ways to get that bottom-up approach going. And that's where, in schools, how many of you are educators? We're hoping all of you have safe rooms in your schools. I know there's a bit of a kerfuffle about seclusion rooms, but safe rooms and snoozling rooms, that's what we call at CASA, where there's a sensory motor room. So there's colors and calming shapes and calming music and calming fragrances in these safe rooms where kids can go, not because they're being punished, but because they need to be safe. And then when they're safe, they can come up their brain, go back to school, into the classroom, and learn. And that is all of our 5 outer senses plus more, sight, sound, taste, texture, touch. And when those 5 senses are out of whack in kids, and there's things called sensory integration disorder where they're not well integrated, all bets are off, because until you're comfortable in your skin, I don't care what kind of therapy you do or what kind of med you deliver, you need a kid to be comfortable in their skin. So schools ought to have these safe rooms where you don't go in as a punishment, you go in proactively, calm yourself down before the big kerfuffle arises, and we have to call for restraints or whatever. So those are some of the efforts we're trying to do to get more of the bottom-up going on. And if we get to probiotics in the school, well, boy, that would be great, right? So
we're over time, but does anybody else have a pressing question?
I'm always the one that someone comes up afterwards. I'm sure it's the same with Gayla and maybe these lovely ladies is, well, I could never ask you in a group, but could I ask you personally? So yes, we'll be here after the production is over, and we'll chat with anybody who'd like to.
Hi there. Just a quick question. The lady on the right here had mentioned that we have to start working with the bullies, and that's the first time I've heard that. I was bullied. I became a bully, and it took me a long time to get through that. But when you said that, it hit me because of how I feel, and I believe that we have to, help the bullied, but it starts with the bully for me, and there just hasn't been a lot of or enough safety out there for us to step past that. And not to say that there's not counselors and stuff like that. I had good mentors growing up, but I had to fit in, right? So there wasn't always enough resources or many resources for me, for other bullies to feel safe to work on that.
We need
Yeah. Throw a spiral.
Yeah, I can catch sometimes. I'm really glad that resonated. And I think the reason why I feel compassionate for victims and for bullies is because in the office, I'd have to say it's 50-50, right? 50% of the cases are victims of bullying, and 50% are, if we want to say, perpetrating. But I often think that when we think of transgenerational traumas, or if we're victims, if we perpetrate because that's what we know, right? And so I think it's unlocking the dialogue around what that means, and demonstrating some compassion for someone who is trying to organize their story. If you feel like you're powerless, I think the move is to find power somewhere. And so we'll see it all over the place. We'll see it in schools, and we were talking before, we see it with adults too, where it just sort of perpetuates. And if we have more compassion, I think for both sides of that conversation, I think we're going to be making more progress. So
If I could address that, so in looking for power, I've treated lots of boys who got bullied, and they thought, well, the defense mechanism is called identification with the aggressor. I'd rather be on the team that's winning than the team that's losing, so I'm going to go over and be a bully. But that third section called the bystander is where we need to find power now. And I think that's a movement that is growing. And whether you look at the Me Too movement, or how many people are very actively into animal protection or climate change or whatever the cause might be, it's don't be an innocent bystander, be an enlightened bystander. And that the kid can move from being bullied into being a bystander with other groups of bystanders who are enlightened and feel power as a bystander. And then they speak up and say, no, let's not do either of those, the bully or the victim. Let's all, kind of get along here. But that's the voice that needs to be heard, and I think that's what's getting better at schools.
Wow. I think that's a great way to sort of end the discussion. Just a few final words from each panel member.
Oh, gosh.
What do you want to take? What do you want people to leave with? I know it's a big topic.
Yeah, that's a big topic. I would just say, I think trauma-informed to me means just being aware of the ACEs, right? That everyone around, there could be 3, 4, 5, and sometimes I think we prepare for 1 or 2 ACE, we think, okay, that behavior could be related to trauma, but I think we just need to be more mindful that ACEs are out there and they affect our behaviors, and sometimes peculiar things that we want to scratch our head are actually for something that is a little more deep-seated. So just being mindful of ACEs, I think, in our communities, I think would make a big difference.
For myself, it would be don't be afraid to reach out for help. Continue to break the stigma and educate yourself. That's, to me, is huge. And we need to keep talking.
Well, for me, it's practice compassion. So as adults, society sort of tells us, you better discipline this kid or they'll turn out, A, B, C, or D somehow wrong. But the other side of that coin is you need to practice compassion so that they will be healthy in their relationships. So for me, it's practice compassion.
I think my hope is that everyone understands to listen and to take the time to listen, especially if a youth is reaching out to you or anyone is reaching out to you. It's important to understand that sometimes it's not advice that we're seeking, or it's not getting in trouble that we want. It's just listening. That's all we want.
And if I can have a final say, I spent all of yesterday afternoon just on YouTube listening to different speakers talking about this subject, and it's way, way bigger than I ever anticipated, and it's something well worth learning more about if you get a chance. And thank you so much. Dr. Bremness, what an incredible talk. There's not very often I go to a talk and it's just wow after wow. Thank you. That was fantastic.
You're very welcome.
Yeah. Betty, Thank you for sharing your story, and
Yes, thank you.
Cassandra. And Gayla, the work that you're doing, wow. The university's in for, here comes Gayla. And thank you very much, audience, for being here this evening. And as I mentioned earlier, you're welcome to stay and talk to some of the panelists. And also, you may have noticed there's a cameraman here. So this has been recorded. So if, I noticed a lot of you were taking notes and taking pictures of the slides. But if you'd like to go back and see the presentation or any of the discussion, the video will be up online. I'm not sure when, but up online shortly. So you can go back and revisit if you like. Denise has final words.
Thank you, thank you. Really
The
appreciate this.
boss always gets the final
Oh, no,
word,
no. Thank you, everybody, for coming this evening. This was a very intense session, sitting in the audience, I'm just letting you know. And I appreciate everybody coming and staying. Thank you, Leslie, Cassandra, Dr. Bremness. You are CASA's foundation. Betty and Gayla, thank you. We have a small gift for you. I'll spoiler alert, it's a talking bowl. Okay, so we just want to encourage everybody to keep the conversation going. We have Dr. Jean Clinton coming from McMaster, October 16th, and the focus is on infant and preschool mental health. Please be sure to follow the CASA Foundation on the Facebook and Twitter. Check back to the website, see if there's any changes. We'd really, really appreciate you filling out the evaluation. That helps drive the conversation. As Leslie said, the panel and Dr. Bremness will be outside. Again, if you've got any questions, just connect with us at feedback@casaservices.org, and have a great evening. Thank you.